We'll just give a few minutes for other participants to join, and then we'll get started. So just encouraging us, please. Thank you very much. I can see the introductions already coming in the chat box. Thank you. Excited to meet everyone. Thank you for joining us today. If this is your first time, this is the Project Aisha Tele-Education session. One of our interventions under the Project Aisha, which is we'll get to know more about this, but this is a maternal health project, and a big goal is reducing maternal mortality, improving maternal mortality outcomes, and reducing obstetric complications. So we're excited that you are joining us to learn today. Our speaker is here, and I can't wait to learn and to glean from her seasoned insights. I believe you are as well. So we will kick off very shortly. Thank you for joining us today. Thank you to everyone still joining in. Welcome to today's session. We're starting in a few minutes. Just want to encourage you, please introduce yourselves in the chat box. Let us know where you're joining us from, the name of your facility, the name of your state of where you're working in, and maybe your country as well. Let's get to meet everyone today. Thank you so much. Good afternoon, Babatunde Jimoyabo. Welcome. Thank you for joining us today. Thank you very much for the music. Just as we're waiting for a few people, let's just, stir up ourselves a little bit, and we'll get started shortly. Thank you. All right, we're starting in 1 minute. Welcome. If you're just joining us, we're just giving a few minutes or 1 more minute for other participants to join in, and then we can get started. Thank you so much. Welcome to today's session. All right. Thank you very much for the music. We would start right about now. Welcome once again. Good afternoon, everyone. Thank you for joining today's Project Aisha session. I can see that our introductions are already coming in the chat. Thank you for letting us where you're joining us from. I'd like to encourage as many people as can. Could please turn on their videos. Let's get to see ourselves, so we can all be together in the room. Welcome, welcome. Next slide, please. Last year, we had we kicked off the series, Special Conditions in Pregnancy, with the topic Hepatitis B in Pregnancy is the back worse than the bite. And it was quite an engaging session where we learned from our speaker. Today, we are continuing that series with an interesting topic, Special Conditions in Pregnancy Part 2, Sickle Cell in Pregnancy. And as we know, or if you're joining us for the very first time, Project Aisha is a consortium-led project supported by MSD for Mothers and being implemented in Lagos State and Kaduna State, with the big goal of reducing, driving zero preventable deaths for women and children during childbirth and reducing, deaths from obstetric complications, and ensuring that no woman dies while giving birth. So we're excited for everyone who's joined us today from our implementing facilities, from other facilities. It's going to be an interesting session where we're going to learn from our speaker on understanding the link between, that obstetric burden of sickle cell disease and how we can support patients with sickle cell disease and, and improve maternal outcomes ultimately. So thank you for joining us today. We're going to get started right away. Next slide, please. Thank you. So like I mentioned earlier, we have a number, about 40 facilities, where we're implementing in Lagos and Kaduna states. Across mixed system, public and private facilities. And we thank every one of them who is already present here today. Please signify in the chat, what facility you're joining us from. If you're from one of our Project Aisha facilities, we're excited that you joined the session today. Thank you so much. Next slide, please. Of course, it's always very important for us to recognize and celebrate the amazing, wonderful experts, subject matter experts who have contributed to the success of our sessions in the past. Thank you for your didactic presentations and for the learnings, value-loaded learnings that our healthcare workers have taken from these sessions. Let's continue to contribute to building capacity. Little housekeeping. I'd like to let us know that Project Aisha leverages the ECHO model. So we will collect, certain information around your registration, your participation, questions and answers. We would like to highlight that your data will be used, for reporting purposes only and will be handled and kept confidential by only authorized personnel. Thank you. Please also take note that this session is being recorded and we'll be sharing a PDF version of the slides after the session for your continued learning. Next slide, please. Once again, I would like to encourage us, please have your cameras turned on. If you need to speak, you can use the raise hand feature and you'll be given the opportunity to be unmuted to speak. We also like to encourage you, please use the chat box for your questions. Keep your questions coming in. We'll take them in the order in which you receive them. If you're having any technical glitches, members of our team are on standby to provide that support for you, and there's a number in the slide as well that you can reach for additional support. Next slide, please. Awesome. So a quick run through our agenda. We began with welcome introductions and running through our guidelines. We'll take a look at some of our reviews from some of our facilities. We'll take a pre-quiz as is our custom. Our speaker, who is already in the room and who can't wait to share with us, will give us a presentation on the topic that we're looking at today. Then we'll take a case presentation from one of our facilities. Would receive an expert's insight and response to the case presentation by our speaker. We'll have a quick segment for questions and answers and discussions. We'll take the post quiz, which is primarily for measuring our knowledge gain, and then we'll start to bring the session to a close. Next slide, please. Awesome. So before we go ahead, I think it's very important that we understand, what MDoc is, about MDoc, who are we, why Project Aisha, why MDoc, right? And it's important to highlight that MDoc Healthcare is a digital health company that's optimizing the end-to-end self-care experience for persons either living with chronic conditions, a subject of which we'll be speaking about today, or even regular health needs, and we harness quality improvement methodologies, data, behavioral science, and technology. Our overall goal is to ensure that people have the abilities, to be able to live healthy and happier lives and be able to advocate for their healthcare. And through our four-pronged approach, which is our Complete Health app, where members are onboarded on and can receive digital knowledge and virtual coaching support to be able to take the right actions to improve their health and well-being. Additionally, we have what we call our Navi Health, which is our geocoded database or directory for healthcare facilities, where you can find facilities, with the specific services that you need. And people are also allowed to give reviews on the experience of care to further drive improvements in these facilities. Lastly, thirdly, our MDA Quality Network, which is the platform for delivering tele-education sessions like what we're having today, and also our asynchronous sessions, learning sessions via our learning management system. And then lastly, our Nudge Hub. So while we're a digital focused organization, we also recognize the need for in-person support. And so we have these in-person community hubs where persons can work in, members can work in, check their health, have their health metrics tracked, and receive support from their coaches. We'll take a short minute to just take a look at our Complete Health app. Next slide, please. Thank you so much.
Hello, in this tutorial, I'll walk you through the sign-up process on NaviHealth. The first step is to enter navihealth.ai into your web browser. Next, click on the sign-up button you can find below. Choose from one of the options to register either as a patient, facility, or healthcare provider. Input your details. You can use a registered phone number or email address of choice. But please note that using a registered phone number is compulsory. Make sure to create a strong password. Once you have done that, click on the Finish button to be redirected to input a 6-digit verification code. Get this code sent to your email or your phone number and click to verify the button to complete the sign-up process to get started on NaviHealth. Once the sign-up process is complete, search for a healthcare service close to your location, and once the result pops up, you can search for a facility close to your location. Once you search for a facility, you can click to leave a review on that facility. Make sure your reviews are 100% authentic and original. Input a display name which is not your profile. And thank you for using NaviHealth.
Thank you very much for playing that quick video. Links to NaviHealth will also be shared in the chat box for us to also test out and familiarize ourselves with the system. Speaking of NaviHealth, we'd just like to take a run through some of the insights we've received from women's feedback on the quality of care they've received at these facilities across the dimensions of care. We see for patient-centered care, a patient is saying they were communicating with me every step. The doctor took his time to explain what was wrong with me. Friendly staff. Another review has, when I was in labor, the staff was rubbing my back, which is very rare in other hospitals. On effectiveness, we see the staff are not timely and too distracting in discharging their duties. They are good in attending to those that will bribe them after service rendered. This is a not so positive review. And on timeliness, we see they're not very serious about their job because the first time I brought my baby here, they didn't attend to me until after 30 minutes. So these reviews are important because they're very helpful for the facilities to be able to drive improvements. We would like to take a quick, before we go ahead to the pre-quiz, I would like to take a special minute or moments to just appreciate the chairman of the MPDSR, Lagos State, Dr. Imosemi. Thank you so much, Sha, for joining us today. We really appreciate you taking the time to join today's session, and we're excited that you are here. Thank you very much. So we'll go right ahead to the pre-quiz. Remember that your answers are completely anonymous. We'd like to encourage everyone to please attempt the questions in the pre-quiz. We can launch the poll now. Thank you very much. Awesome. If you can see the pre-test quiz, please begin to take it. If you would like support, our team is on standby to provide that support to you. Confirming that we can start to see the polls now. All right, thank you so much, everyone. If you're having any technical glitches, please let us know and we'll be able to provide support to you. Thank you to everyone who's already answering the question. Please keep your answers coming in. We have just a few minutes to run through the pre-quiz. This is purely for measuring our knowledge gain. Thank you, Dr. Orede, for joining today's session. I know you're quite excited, and I'm glad that you're here. Thank you for joining us today. If you're having technical glitches accessing the pre-test quiz, our team members are in the chat box providing technical support. So please look in there and you'll be guided on how to take the pre-test quiz. Please keep your answers coming in. Well done, everyone. You're doing so well already. Thank you. Please keep your answers coming in. I imagine that some of us are already thinking this takes us back to, med school days, but don't worry. Keep your answers coming in. We'll take the responses to the quiz questions at the end of the session. Thank you so much. We're doing so good already. We have just a few more minutes to go and we'll round off the pre-test quiz. I can see that Olakweju Ajala can relate to med school days. Well done. Thank you for your responses. Please keep your answers coming in. Thank you very much, everyone. We're almost there. If you're just joining us, we'd like to encourage you to please take part in the pre-test quiz that's going on now. This is purely for us to measure our knowledge gain. Please remember that your answers are anonymous. So please take the time to attempt the questions as much as you can. If you're having any challenges locating the questions, please let us know in the chat box, and our team members will be on hand to guide you or provide support for you. Thank you very much. We have just 1 more minute to go. We'd like to encourage you, if you're just joining us, please quickly take the pre-test quiz before we round off. Thank you so much. If you're still struggling to access the quiz, please go to the bottom of your screen and click on the 3 dots where you have more, and it will pop up. You'll be able to access the quiz. If you're using a laptop, please go to the bottom of the screen, click on polls and quizzes, and the quiz will pop up. Thank you so much. Please let us know if you've been able to find it so that we can support if need be. We have just a short while to round up the quiz. Thank you to everyone who has attempted this question so far. Thank you so much. I'm sure this has been an interesting experience for you. We will take the answers to the questions at the end of the session. So thank you very much, everyone. I see that some people are just running off their answers, so please, we're waiting on you so that we can bring this to a close. Thank you so much. All right, we've done so well already. Thank you everyone for sending in your answers. We will be bringing this to a close now. Thank you so much. So I think we can end the poll now. Thank you everyone. Next slide, please. Wonderful. So we've come to the meat of today's of the matter today, and it's my honor and pleasure to introduce our speaker, renowned maternal health researcher, experienced physician, and professor of obstetrics and gynecology, Professor Bosede Afolabi, who is also principal chief investigator, as well as attending consultant obstetrician and gynecologist and director. She's a professor of obstetrics and gynecology in the College of Medicine, University of Lagos. She's a maternal medicine expert, has a DM from the University of Nottingham, UK, and is internationally recognized for her research and clinical care in sickle cell anemia in pregnancy. She's a fellow of the Academy of Medicine Specialties of Nigeria and of the Nigerian Academy of Medicine, as well as lead investigator of several research projects with grants from TED Fund, NIH, USA, and the Bill and Melinda Gates Foundation, amongst others. She's director of the Center for Clinical Trials and Implementation Science in the University of Lagos, and the founder chairperson of the Maternal and Reproductive Health Research Collective, a non-governmental organization committed to improving the maternal and reproductive health of Nigerian women. Professor Bosede has a certificate in epidemiology and biostatistics from the Harvard T-Chan School of Public Health, Boston. She mentors postgraduate students, including 7 PhD students and junior academics in various research projects. I should be seeing the claps in the chat box by now. She has authored over 110 publications. That's mind-blowing. Her more recent accolades and awards include the 2023 Goalkeeper at the UN General Assembly, Excellence in Research Award by the Society of Obstetricians and Gynecologists of Nigeria, November 2022, the Ojo Memorial Lecturer at the 56th Annual Scientific Conference of Sogon, November 2022, Special Recognition Award 2021 by the Physician of the Year Awards Committee. She is the president of the Association of Fetal Maternal Medicine Specialists of Nigeria and is on the board of directors of Redwire Marketing Group, as well as the advisory board of Sigen Pharmaceuticals Limited. She's the chairman of the board of directors of the Kensington Bosede Bukola Foundation Laboratory and Maternity Center, a private maternity center situated in the University of Lagos. Prof clearly wears so many hats and wears it so well. Please, if you're not clapping, Prof is not going to take the mic to speak. So please, you need to celebrate the icon, the remarkable trailblazer that we have in our midst, who is here to deliver today's didactic session. Prof, thank you so much for joining us today. I'm happy to hand the mic to you now. Thank you. Prof, can you hear me,
please? Thank you very much. Yes, awesome. I can hear you. Awesome. Thank you very much, Elizabeth. I did give you the bio, but it always sounds very strange and very interesting and what's the word now? Strange when it's read out in public. Thank you. You're welcome. Thank you as well for your patience with me during this process. I know that I wasn't the easiest of presenters because I kept telling you that, look, I'll show up, don't worry, but I'm busy, so stop telling me to come for rehearsal and all sorts of things. But I'm here and I've shown up, and I also corrected your questions and so on. So thank you very much for inviting me. I always like to speak about sickle cell disease in pregnancy because this is where I caught my clinical and research subspecialization teeth. And it's an area that I'm very passionate about. I go, bend over backwards to look after women, pregnant women with sickle cell disease, because I know how difficult it is to live with that condition, especially when you're pregnant. Without too much ado, I'm going to go quickly into the presentation so that we don't waste too much time today, because like I said, I do have a hard stop at about 3:30. So this is our beautiful College of Medicine here. And I'm going to speak on the background on sickle cell disease briefly. I'll talk about pathophysiology and presentation, and then move quickly on to the clinical features in pregnancy. I'll talk about some evidence on pregnancy-related complications, how to manage it during pregnancy and postpartum, and any updates. Now, I'm also going to speak broadly. I know that we have a broad audience here. We have physicians, we have non-physicians, we have some sickle cell warriors. So it's important to channel my talk to all the different levels, and I'll try my best to do that. Next slide, please. So to the pathophysiology and the mutation, sickle cell disease. Sickle cell anemia refers to SS only, but sickle cell disease includes SS, any S and any other abnormal gene. So SS, SC, S-beta thalassemia are all sickle cell disease. When you say something like CC, even though it's a hemoglobinopathy, is not seen as a sickle it's not seen as sickle cell disease per se. So please take note of that. For sickle cell disease, there has to be one S gene mutation, and then the rest can be any other abnormal ones. So AS is not sickle cell disease because A is a normal hemoglobin gene. So the mutation is mainly in the beta gene, and that's what makes the difference. So hemoglobin is heme plus 2 globin chains. And if you look at this diagram on the right, the beta chain is where the problem is. And that beta chain has 146 amino acids. And on the 6th position, there's a mutation in the 6th amino acid glutamine to valine. So instead of it being glutamine, the amino acid there being glutamine, it's converted to valine, and that's what causes a lot of all the abnormalities. For HBC, glutamine changes to lysine. So those are the two differences when it comes to S and C. Inheritance of sickle cell disease is in a Mendelian fashion, and that means that it's an autosomal recessive inheritance. So the probability of if two parents, I think the next slide might have that diagram. Yeah. So if two parents, AS, A to A, will give an AA baby, A to S there is AS, S to A there is AS, and then S to S is SS. So that is a 1 in 4 probability. However, this does not mean that if they have 4 children, only one will have sickle cell disease, unfortunately. It could be that all 4 will have it. It could be that none of them will have it. It's each time there's a pregnancy that you have that probability of 1 in 4. So there's a probability of having 1 in 4, a probability of 1 if 25% chance of having a baby with sickle cell disease. Other genetic mutations exist. I haven't finished with the previous slide. Okay, I've said that it's inherited in a recessive pattern. Next slide, please. So Nigeria actually has the highest number of women living with sickle cell disease in the world, and they account for 2 to 3% of the population. So people living with sickle cell disease, highest in Nigeria. So 2 to 3% of the population have sickle cell disease. It says, we usually say about 150,000 babies are born every year with sickle cell disease in Nigeria, and that's still something that is continuing. It used to be seen as a disease of childhood, as very few people survived past the age of 5. We've had improved survival over the years, and more recent figures are telling us more than 50% of people with sickle cell disease survive after the age of 5, approximately 50% now. And many of these women and men are now surviving to pregnancy. Next slide, please. Now, what exactly causes this problem? If you click again, I think I have some pictures that I would like to. Another click again. So basically, that sickling that we say occurs because polymers are formed. And what are polymers? Polymers are substances that are not very smooth, as it were. Let's just put it that way. So you have hemoglobin polymerization, and they are very fragile, such that when you have any states where you have a lack of oxygen, or you have dehydration, any stressful state, and that includes pregnancy, the hemoglobin that is this sickle hemoglobin changes position, becomes fragile, and then changes into that shape that we call sickle shape. And that's where the disease gets its name, because of if you look at this, unfortunately, I can't. No, I can't, because I'm not the one doing the slide. But if you look at the top diagram, there are some thin shaped, yes, the thin shaped structures there, as opposed to the round ones. Yes, that one in particular, that is a sickled cell. and the others are red blood cells, normal looking red blood cells, but some of them have sickled. So what exactly causes the features of this condition? Because the cells break down so quickly, the normal lifespan of a red blood cell is about 120 days, but for sickle cells is about 20 days. So because they break down so quickly, you have anemia. They have women with people with sickle cell disease. Sorry, I keep saying women because those are the ones I look after. But people with sickle cell disease have chronic anemic states, which means a low red blood cell availability. And so they break down their red blood cells very frequently, and that causes the anemia. Then also, these sickled cells, these shaped cells, also cause a blockage of the blood vessels in which they are passing. So if you look at the lower diagram, these sickled cells block them because they don't, the roundish ones are supposed to squeeze through easily, but the sickled ones don't. They block those cells. And because they block the cells, the supply to the organs that they're going to, for example, the bones, especially the long bones, is reduced. And that's what causes pain. If you squeeze anything and reduce its blood supply, there's pain in that area, is what happens with them. And that's why you have this vaso-occlusive crisis, which is the common one, which we also know as bone pain crisis. We also have thrombosis, because these blood cells, not only do they reduce blood supply to an organ, they also block the blood vessels. And when they do that, that's when you have things like stroke. That is caused by blocking of blood vessels. And you even have stroke in children, very young people with sickle cell disease. There's a way of finding out if there's a risk for it, and that is one of the ways in managing the condition. Then infarction is when, after the blood supply has gone really reduced, the organ that is targeted may now die off that area, and that happens in the lungs and in the bones. So what triggers all these problems? Infection. So that's why people with sickle cell disease should try and ensure that they keep away from getting infected by, keeping all the necessary avoidance of any infected person, or hand washing and doing all the necessary infection prevention procedures. Hypoxia, that is if they actually either live in a very high area where the oxygen saturation is low, or if they're in a place where they can't get a lot of oxygen. Dehydration, which is why we always say, please drink water as much as possible. And temperature changes, so don't be too hot or too cold. All those things trigger the problems that that causes sickling of the blood cells. Pregnancy is also a trigger, because pregnancy is a high hemodynamic state that has plenty of blood turnover and can have some stressful substances released. So the complications of sickle cell disease, what are the clinical features and how do they manifest? In pregnancy for sickle cell, sometimes for some women with sickle cell disease, actually, they don't have any problems during pregnancy. Maybe about 30% of them may go through pregnancy without any problems. But majority, a lot of the time, more than 65%, and there's some work we did to show this, of them would have at least one crisis in pregnancy. A lot of them have two or more during the pregnancy. So there are more frequent crises during pregnancy for the mother. Infections are also more common, both urinary, respiratory, and any other infection. Acute chest syndrome is a condition that is quite severe in people with sickle cell disease generally, and we tend to find it quite a bit in pregnancy. Malaria is also seen in pregnancy. Hemolytic crisis, where not only do they have the bone pain, but they also now have a breakdown of their red blood cells in a very rapid manner, more rapid than usual. That's what we call a hemolytic crisis. Preeclampsia, which is a pregnancy-induced hypertensive state. Admissions, operative delivery like cesarean sections are more common. Thromboembolic events, so having deep vein clots in the legs, which sometimes travel to the lungs, that's what we call pulmonary embolism, also are more frequent in them. And having a miscarriage, they're more likely to have miscarriage. And unfortunately, women with sickle cell disease are more likely to die during pregnancy than those with hemoglobin AA. Having said that, it's still something that can be prevented with very good care. And we had a series where we had 50 consecutive women that were registered under us in our institution over the space of about 2 years, and we didn't lose one woman with sickle cell disease that, from that cohort. So it's doable, but it takes a lot of individualized and dedicated care. Next slide, please. For the fetus, as you remember, in pregnancy, we have two patients. We have the baby that the woman is carrying. There's a higher risk of being born prematurely because of the condition. There's also a higher risk of low birth weight, the baby to be small at birth. And not only is the baby small, the potential growth for any baby is, for any single baby, can be reduced, that is the potential growth rate, such that the growth is restricted. So the smallness could be because they are small, generally because their mothers are small, but you could also have a growth restriction, that is, they don't grow to the potential that they are supposed to be able to grow to. For those reasons, there's an increased risk of death as well in the fetus. Having said that, all these prognoses, all these problems, they are improved by multidisciplinary and individualized care. Here in Luth, we have a team of obstetricians, hematologists, microbiologists, respiratory physicians, anesthetists, that we all work together when it comes to the care of these women. And we've even started forming these ad hoc multidisciplinary WhatsApp groups to, just focus on a particular woman when we realize that, okay, this woman is looking like she's in trouble. Let's get together and start, doing some real-time treatment. So we're by her bedside, and we're also messaging each other to say, this is what is going on. What do we do here? And that has really helped. So in terms of, this is just something, one of our papers, a very, very well cited paper, because we showed clearly the outcomes according to hemoglobin phenotype using a case control study design. And we showed that clearly there's a difference in birth weight, significant difference in birth weight, APGAR scores when they're born, as well as the death rates from women, over 150 pregnant women with sickle cell disease. Next slide. But that was like 2009, quite a long time ago. So how do we look after these women? How do we look after these women during pregnancy? Ideally, it should start before they get pregnant. Management should be preconceptual. And when a woman that has sickle cell disease is about to get, or knows that she wants to get pregnant in the near future, she should see us even before she gets pregnant. And we should ensure that we do basic tests, like making sure her blood pressure is normal before pregnancy, checking her urine, and also doing a kidney function test to be sure that she doesn't have sickle cell nephropathy, because that's another condition that can occur. Like I remember I said there are some end organ damages, and the kidneys sometimes do get affected. Because if you identify the proteinuria, that is the protein in the urine, you can actually treat before it progresses to severe renal disease. And proteinuria does tend to worsen in pregnancy. You also need to screen for pulmonary hypertension by doing an echo. So ideally, we should actually be doing echoes for women with sickle cell disease when they come before they get pregnant, blood pressure, urinalysis, renal function test, and so on and so forth. Sometimes it's difficult to know if sickle cell nephropathy is what is going on, or if the woman is developing preeclampsia, because they both have protein in their urine, and they also can both have high blood pressure. And we had one woman like that recently that we couldn't, because if they have preeclampsia, ideally you should deliver them immediately. But this woman seemed to have had the protein in her urine for, since as early as the first trimester, which you can't, that's not preeclampsia. But we couldn't be sure because she came to us late. So at some point, we're thinking, does this woman have preeclampsia, or does she have, nephropathy? Should we deliver her now or still give her some time? But at some points, the protein in the urine got so high and her blood pressure was getting so uncontrollable that we said, okay, it's time to stop here. Even though the baby seems to still be doing well, relatively well with ultrasound. But when we had a reduction in the liquor volume as well. We said, okay, let's stop here. So we delivered her at 33 weeks, and thank God she went home with her baby. It's important to do the full blood counts to ensure that the hemoglobin is at their steady state. That's a steady state that we tend to talk about quite a lot. Now, steady state is not magic, and it's not necessarily always that accurate, because the woman may not know what her steady state is, or may just have been told one figure once. But if she knows, it's quite useful, because some of them would have a steady state of 28%. Okay, of PCV. And if that is the case, then you want to try and make sure that they are around that 28%, not too low, while some will have a steady state of 22%. So if you say, oh, this woman has an HB of 24%, and that means she's okay, because most sickle cell women would have an average of about 24%, then that may be too low for somebody that is supposed to have 28%. So that's why the steady state thing is important. But you may have to look at other parameters if the woman is not sure of what her steady state is. If the hemoglobin is low, try and get them to delay conception so that you can treat them, and also delay conception if they've recently had a crisis or transfusion, because we know that pregnancy worsens the prognosis of crises. Discontinue if they've been on hydroxyurea, which is a drug that is used to reduce crises. You should discontinue it till at least 3 months before they get pregnant. But if they are using it already when they get pregnant, you have to counsel them to stop, because it's not known to be safe in pregnancy. Having said that, a lot of people have used it in the past and gotten pregnant without it necessarily causing a problem. But once you know about it, you're supposed to stop it, because it's potentially teratogenic, that is, it potentially causes problems with the fetus. You should screen the partner. That's key, because it will be very, very sad for a woman to be SS and be marrying pregnant with an HbAs man without knowing, because that means that their risk of having an SS baby increases to 50%, as opposed to if there were two AS people. SS with AS, 50% risk of having sickle cell disease. Now, information, of course, give them a lot of information, tell them about avoiding dehydration, temperature extremes, as well as stressful events, and that they should make sure they register in hospital early, as soon as they get pregnant, because then you can look after them better. Next slide, please. So the management, like I said, multidisciplinary, I can't overemphasize that. It's important to take a history like every other condition in pregnancy or non-pregnant. You should take a good history, try and find out the pattern of the previous crisis, how recently does the person have frequent crises, transfusion, how recently they've been transfused, full blood counts, blood group, genotype, syphilis test, the usual booking tests, HIV, hepatitis B, malaria parasites, and MSU, that's urine for microscopic culture sensitivity, because there's a risk of infections, like I said. I put the ideal genotype method in that ideally you should do HPLC, but that is really the ideal, and a lot of people can't afford to do that. So electrophoresis is also okay, but the important thing is that they should have the genotype done appropriately if they don't know their genotype already, or if they're not sure. Sometimes you have somebody come and say, oh, they said I was SS, or they said I was SC, and somebody said it's SS here, somebody said SC there, somebody even said I was AS. So to confirm, you may have to do a proper HPLC genotype testing. We advocate folic acid 5 milligrams daily, as well as proguanil, that is anti-malarial 200 milligrams daily. However, it's not actually clear whether we should be given, we can't use sulfadoxine pyrimethamine to prevent malaria as we do for non-HBSS individuals, because it's cheaper and it's, proguanil is more expensive. We don't know for sure which is better, and it's a research question that it will be good to answer, and I'm trying to work on something to answer this question so that we can stop making these women spend so much on their antimalarials. For now, though, if they cannot afford the Progranil, then the best thing is to make sure they are taking monthly Fancida, which is the same thing as sulfadoxine pyrimethamine. Another thing about the management that I must mention is the issue of iron. We often, exclude women with sickle cell disease from taking iron. However, some information is beginning to come out that, yes, they tend to be iron replete. Replete meaning enough iron in them generally on a regular basis when they are not pregnant, because they've had the blood cells in them break down. They don't lose it. They are not anemic because they are losing blood out of their body. They are anemic because their red cells are breaking down inside their body and they are retaining the iron. However, despite that, it's not as if they are getting more iron. It's only if they've been transfused frequently that they are getting more iron than the other person. So if that is the case, pregnancy, we know there's always a drain on iron resources by the fetus. And since that is the case, people are beginning to find out that perhaps these women should actually be taking iron after all. But we don't have the full answer to that yet in our environment. So the best thing to do is, if you think this woman is anemic and she's not, gaining too much, and you don't think is at the level where she needs a transfusion, you could do her iron panel studies to check if she actually is iron deficient and give her iron supplementation. And we're planning to test that soon as well, so that we can get away, because the pregnancy is an iron depleting state because of the fetus. The fetus needs extra iron. You need more iron during pregnancy. And we're not totally sure if they are women with sickle cell disease should be excluded from getting this iron for their babies continuously. Next slide, please. At each visit, we're talking about the pregnant woman now, you should check for symptoms of any illness, ask if there's any problem with the woman, check her vital signs, and then you should ask them to also drink enough water. 3 liters a day is quite a lot, especially for women that are small. So you should be careful about the amount of water they should drink. But drinking it is still better than IV. When it comes to IV, you have to be careful and reduce the amount of IV that they're taking. But drinking, they should drink as much as they can tolerate, and definitely more than 2 liters a day. They should take their routine drugs, the folic acid and the antimalarials, and if they are taking anything with iron, they should take it regularly. They should be advised to keep away from the extremes of temperature, and their visits should be every 2 weeks till 28 weeks. Sometimes some people will do every 4 weeks till 28 weeks, then more frequently till delivery, because of the feasibility of them attending hospital that frequently. So it's really up to how well the woman is. But basically, they should have more frequent visits than someone who is not does not have sickle cell. Next slide, please. So ultrasound scans, so we've talked about the mother herself now. Now, how do we monitor the baby? Ultrasound scan should be done when the woman books, that is when she registers for the pregnancy, so as to date the pregnancy. We should do the usual 18 to 20 week scan to check the baby's anatomy. And then ideally, we should actually do 4 weekly scans from 24 weeks to detect IUGR. We don't tend to do that a lot and enough, and it's important to take note of that. We should scan, because IUGR is an issue, and you could end up having increased perinatal mortality if you're not also surveilling the fetus. If the scans are unaffordable, you have to do your careful symphysiofundal height, and then if it looks as if it's dropping, make sure you scan then at least. However, as you know, ultrasound scan is more accurate in detecting symphysiofundal intrauterine growth restriction. You should admit the woman if there is evidence of a confirmed PCV drop of more than or equal to 3% between consecutive visits, or to below 18%, unless you're sure that the woman's steady state is definitely 17, 18. I had a woman like that. Her steady state was like 16%. And so you can't just keep transfusing her until it's close to delivery. So she was on, and she had also had some transfusion reactions. So she was on erythropoietin for a while to just keep helping build her HB. And she didn't actually need transfusion until maybe at delivery. Febrile illness, if they have any febrile illness, they should be admitted. If they have any type of sickling crisis, bone pain, hemolysis, any type, they should be admitted. And any other obstetric or medical indication that changes the vital signs. So one of the things we do in my clinic is that when, most of the time when pregnant women come, we don't tend to do more than their blood pressure. For them, not only do we do their blood pressure, we check their pulse, we check their oxygen saturation, because sometimes their respiratory rates may be normal or maybe normal, and their oxygen saturation is low because they're anemic. So it's important to check all their vital signs for every visit, and also check their abdomen to ensure that there's no increasing liver enlargement or spleen enlargement if their spleen has not already gone. So this is just, I won't go through this. This is just a pragmatic way of carrying out their antenatal care, and we published this in a review in the hematology, in the American Journal of Hematology. Sorry, there's this, I can't remember the publication of the American Society of Hematology. So it tells you about what you should do in the first visit, and then also subsequent visits until they are delivered. Next slide, please. So the special points for them: plan for delivery and try to conclude on the mode as early as possible. Monitor their oxygen saturation carefully each visit, and this, even though we don't tend to do that, you should always make sure you have one and consider taking action if the saturation is less than 95%. White cell count is often higher in pregnancy than in non-pregnant and in HbA women, so take note of that. And because automated machines sometimes erroneously interpret nucleated red blood cells as white blood cells. But if the white cell count is, really higher, greater than 16,000 or 17,000, that definitely it seems like this might be infection. And if you're not sure, there's a test called procalcitonin that helps determine whether it's white cell raised due to bacterial infection or not. Or you could do a peripheral blood film with your hematologist to be sure whether the white cell count is looking infected or not. Next slide, please. So certain conditions, crises, hydration, usually with at least 3 liters of fluid daily, but I have to really caution that be careful with your hydration. Most of it should be oral as opposed to, what's it called? As opposed to infused, because you can overload them quite easily. So please be careful with hydration. And then invite the hematology unit early, especially if there's no obstetric experts in their management. Twice daily or daily PCV checks. And of course, pain relief, appropriate pain relief. Transfuse with packed red cells of HbA blood if the anemia goes below 18%, and make sure you're trying to raise the hematocrit to 26 to 28% or to their steady state if known. In cases of acute chest syndrome or pneumonia or vaso-occlusive crisis that is difficult to get over, it keeps coming and keeps coming, you may have to do an exchange blood transfusion. We had a woman, we've had quite a number of people like that. There was one particular woman who, by the time she was 20 weeks, she had 5 terrible crises. In fact, the most recent one was so bad that I remember that that it was the middle of the night. My registrar called me, and my registrar was in tears for this woman who was in so much pain despite getting morphine, and we just, we involved the hematologist, and eventually she had to have an exchange blood transfusion, and that just stopped all the problem, and she stopped having to use opiates. So that issue of, they get addicted, it's not something that you should really label them with at all, because once they don't need the pain relief, they don't ask for it a lot of the time. So the hematology unit is very helps with this quite a lot. However, it is safer to transfuse packed cells if you can't get blood to do exchange blood transfusion with than to delay it because you're trying to find hematology. So if you can't get someone to help do an exchange blood transfusion, then give the packed cells, transfuse packed cells. The beauty of the exchange blood transfusion is that you're removing hemoglobin S and you're replacing with AA blood. So that actually helps make it more things easier for them. Next slide, please. A sepsis, you have to monitor the blood counts regularly to monitor the white cell counts. Then chest X-ray. I noticed that a lot of people are very antsy about chest X-ray for pregnant women. Please, the amount of radiation is very low. Shield the abdomen, do your chest X-ray once you feel that there's something more than a regular cough here. And for them in particular, once they're admitted for sepsis or pneumonia, it's best to do the chest X-ray and they say there's nothing than for you to be wondering and not treating appropriately. Procalcitonin, like I mentioned before, is a blood test that helps to differentiate sepsis from viral or pregnancy-related rise in white blood cell counts. And then for atypical pneumonia, which is what is common for their pneumonias, augmentin and azithromycin are usually what the two drugs used for them. Sometimes we actually need to go as far as using levofloxacin for them when the infections are quite severe. And of course, microbiology, apart from just respiratory team and hematology, microbiology too is very key when it comes to sepsis. Oxygen saturation, if it's less than or equal to 94, give oxygen early. It should be, once the respiratory rate is getting high as well, give oxygen. And sometimes it's difficult to differentiate sepsis or pneumonia from acute chest syndrome. So assume that they are, it's there if the woman is not getting better with your antibiotics, especially if you have done a proper septic workup and you've gotten, either no bacterium or you've given the right antibiotics. You may need to go as far as ventilating them, sending them to ICU, but if you don't have that facility, just a high volume oxygen with non-breathable face mask might be the key way to go. Next slide, please. So for acute chest syndrome in pregnancy, just very quickly, it's usually the woman will have a fever or she'll have respiratory symptoms with new infiltrates on the chest X-ray. It is a very high cause of maternal death in sickle cell disease, and almost close to a high proportion of them would have maternal death. It's caused by pneumonia, or it's one of the attributing factors is pneumonia or infection, other infections or fat embolism, and it often follows vaso-occlusive crises with release of fat emboli into the circulation, then into the lungs. So if a woman has vaso-occlusive crisis, especially in the third trimester, you want to quickly nip it into the bud before it becomes acute chest syndrome. So early and aggressive treatment is important, and it should be multidisciplinary. However, with the maternal medicine expert leading, because we usually know how to take what is required from all the different specialists. Next slide. I'm spending time on this because it's so important. You give broad-spectrum antibiotics for atypical organisms. I've already mentioned augmentin, azithromycin. Sometimes you may need levofloxacin, ICU if possible, simple transfusion in mild cases, exchange blood transfusion for severe cases. In my center, we use manual exchange blood transfusion, and it's something that we've found useful. The hematologists are really great with this, and postpartum hydroxyurea is necessary because of the risk of recurrence of acute chest syndrome. Once they've delivered, it's good to try and start them on hydroxyurea. Next slide, please. So the controversies, I've already talked about hydroxyurea, and that is not thought to be teratogenic in pregnancy. Once in a while, though, you may be forced to give it after the first trimester to women that are constantly having these vaso-occlusive crises. Prophylactic antibiotics in the UK, they still give penicillin during pregnancy. However, the evidence is for children, we know that, and everything is expensive in our environment. We're not sure if the cost effectiveness is clear. Iron is what I've mentioned already. Prophylactic blood transfusion is something that some people also feel, and there are studies being done now to try and determine whether you should actually give every pregnant woman with sickle cell disease blood transfusion, to top their blood up to a particular level every so often during pregnancy, just so as to take them through pregnancy safely. Regarding birth, delivery, cesarean section is common with them, even though it is not actually necessary. You know, they're not supposed to necessarily have a cesarean section unless it is indicated. You should only do cesarean section if there's obstetric reasons and if there are other conditions. Ideally, you should actually deliver them vaginally, safer like it is for everybody else. However, you have severe vaso-occlusive crisis close to term. You have preeclampsia, which is remote from term, or, you know, the woman is already very ill and needs to deliver her quickly. You have some sickle-related problems like avascular hip necrosis, and they can't flex their legs properly, or you have some other obstetric or sickle-related complication, you usually would have to deliver by cesarean section. You should give steroids for reducing respiratory distress and perinatal death if the woman is delivering early. You should give, anytime a woman is admitted during pregnancy or after pregnancy, she must have Clexane. Anytime with sickle cell, anytime any woman, even when she's not due to deliver, once she's on the bed on admission for a crisis, she should be on Clexane prophylactically because there's the risk of thromboembolism. And then we usually keep them longer before we discharge them because of postpartum risk. So we tend to say 4 days delivery, and there's no problems. Next slide, please. Like I said, it should be vaginal delivery unless contraindicated, root and cross-match, HbA, packed cells for delivery, do frequent PCV checks during delivery, give epidural analgesia if you can, or morphine, but not pethidine. Pethidine is not known to be safe in women with sickle cell disease, but pentazocine too is safe. It's just that it's not as effective as morphine. Hospital delivery is a must, and there should be senior personnel involved, give adequate fluids, oxygen, and do your electronic fetal monitoring as appropriate. And if there is any appropriate obstetric reason or the hip is unstable, you need to do a cesarean section. Next slide, please. Postpartum, we're almost done. We must test the baby early for sickle cell disease, just in case you missed the genotype of the father. There should be neonatal newborn screening for sickle cell, ideally in Nigeria. They've been trying to implement it for a while. We're hoping that it will take effect soon. We should maintain optimal oxygenation and hydration of the mother postpartum, thromboprophylaxis, like I said earlier, with Clexane, close monitoring for crises, usually discharge after 4 days. And then postpartum, contraceptive advice is very, very important. We should give progesterone-based contraception because it's effective and is known to even decrease the frequency of crisis. Depo-provera was found to do that in a study done a long time ago. So you can use Depo-provera, Mirena, Implanon implants, progesterone-only tablets, or barrier contraception. Combined pills, they're not absolutely contraindicated, but because the estrogen also increases risk of thromboembolism, we don't tend to give them as first line or even second line. IUCD, the copper T IUCD, we also don't tend to give them because of the risk of increased bleeding. And if there's infection risk during insertion. And of course, if the family is complete, you should encourage them to have tubal ligation, that's sterilization, bilateral tubal ligation, especially after 2 to 3 children. I'm always very, very on my patient's case in terms of their having children, ideally not more than 2. If they must, definitely not more than 3, because each pregnancy is stressful. I think that should be my last slide. So just I've already talked about some of these cases. I think we've gone past time now, so I won't say that anymore. Yes, that one I spoke about that, yeah. And then for new drugs, there are some drugs licensed in December 2023. They've not been used in pregnancy. There's the bone marrow transplants that isn't used in pregnancy either, but at least these are some drugs that we know are available for treating sickle cell disease. The first 2 that were licensed last year, they're still costing over $2 million US dollars per dose. So it's not yet here, but hopefully we'll get there. Next slide. Some work that we're doing in the trial, we've almost finished it, trying to find out if aspirin should be used routinely in pregnant women with sickle cell disease to prevent growth restriction and preeclampsia. we're almost done with it, and we should have results in another 4 to 6 months' time. Next slide, please. So concluding, managing women with sickle cell in resource-limited settings can be challenging to both the women and her care provider. Multidisciplinary care is key. If we can use strategies to implement healthcare with available resources, we can actually look after them properly and reduce their morbidity and mortality very, very keenly. Thank you very much. Next slide. And references. Next slide. Thank you.
Thank you so much, Prof. This has been such a rounded presentation. I'm expecting to be seeing us really thanking Prof for this wonderful, rounded, very, exhaustive presentation. I wanted to ask Prof if it was too late to sign up as one of the students he's currently, mentoring and supporting, because I was taking notes furiously. I had a test to sit for. Thank you so much, Prof. I think that across the continuum of care, it was interesting to see the elements that are very important for monitoring, from pre-pregnancy to even postpartum, understanding why it is. I even found very, very interesting how the hydration is such an important thing to take note of for patients with sickle cell. So thank you so much, Prof, for the points you highlighted. I believe every healthcare worker would listen today has taken away at least 1 or 2 lessons, that will, help and improve the delivery of care for patients living with. So thank you so much, Prof. This was absolutely, absolutely interesting, insightful, and enlightening. Thank you so much. We have a number of questions in the chat, and we'll take them in the order in which we receive them. But we want to quickly go through our case presentation so that we can get Prof's expert insights to it before we have to move on. So please kindly, let's pull up the case presentation. Thank you so much. Matron Ajayi, just confirming that you are in the room and that you are able to speak.
Good afternoon, everybody.
Awesome. Good afternoon.
Good
Welcome,
afternoon,
thank you very
everybody.
much. Good afternoon. We can hear you. Please go ahead.
This is Matron Ajayi from General Hospital Fakojayi, ma. Thank you so much, Prof, for the wonderful presentation. So I'm presenting the case presentation of one of our clients, our patient, that was HBSS. By name, Mrs. S.O. Her age, she was 28 years old. She's married. Religion was Islam. Her occupation, she's a fashion designer. Her level of education was secondary school. She was gravida 2, para 0 plus 1 top, that is termination of pregnancy. Our last menstrual period was on the 26th July 2023. Our EDD, estimated date of delivery, was 3rd May 2024. Genotype was HBSS. The number of ANC visits she had, it was 8 visits. Our gestational age at the early stage was 16 weeks at booking, and she delivered at 40 weeks plus 5 days during her delivery. Next slide, please. Next slide. Please.
Apologies, there's just a small technical glitch. Let's try and fix that so we can resume presentation. Okay, great. Thank you, Matron. Just a little, 1 more minute. Okay, great. You can move to the next slide now, please. I think she's ready for the next slide.
Next slide.
Thank you. Matron is up now. Can you see it?
Continuation.
Matron, she's moved now. Can you see it?
Not yet.
Okay,
So our
sorry.
pain, our present complaint was backache. Then there was new complaint. The medical history was HBSS. There was no allergy. Surgical history new. Then gynecological history. She was para 1 alive. She was para 1 alive. The family history and social history, there was twins in the family, new TB, and no malformation in the family. On examination, patient was in pain, but clinically stable. New abnormality detected. Then the cervical, she was for cervical ripening, which was about 3 centimeters at 20th April 2004 at around 8 a.m. Her weight was 72 kg. Her BP was 110/70 millimeter per mercury. Her pulse was 88 beats per minute. The urine was tested for sugar and protein, which were negative. On palpation, height of fundus was 40 weeks. The lie was longitudinal. The position was right occipital anterior. The presentation was cephalic. The fetal heart rate was 148 beats per minute. Next slide, please. The vagina was warm and moist. The membrane were intact. The general examination, new malnutrition, new clinical anemia. The systemic examination, there was no abnormality. Diagnosis, that was active phase of labor. The management. Patient was encouraged to continue in labor and was counseled on deep breathing exercise. At 5 a.m. of 21 April 2024, she was not progressing in labor, so she was declared for emergency CS due to failed induction, secondary to cephalopelvic disproportion. At 5:45 a.m., she was received into the theater with BP 120/76 millimeter per mercury. Her pulse was 107 beats per minute. Her respiration was 22 cycles per minute. Fetal heart rate was 148 beats per minute. She was on IV fluid, normal saline, 500 mils in both arms, same dripping minimally in her drip. Urethral catheter institute, draining clear urine. Patient was reassured.
Matron, we can't hear you anymore. Are you still able to see the screen? Hello, Matron.
Plus
Okay,
vitamin K.
Okay.
Injection vitamin K. 1 milligram start was given. IM. Around the neck twice. The birth weight of the baby was 3.2 kg. The length of the baby was 46 centimeters. The head circumference was 35 centimeter. The baby was oiled, wrapped, and kept warm under the radiant warmer. Next slide. Next slide. Next slide, please. Okay, thank you.
Okay.
The management continued. The cord was wrapped and same treated with methylated spirits. Condition of the mother. The placenta and its membrane were completely extracted by control cord clamp, cord traction. Injection of oxytocin 60 international units was given in divided doses. Uterus was firm and well contracted. The incision was closed up in layers up to the skin level with different sutures and various strengths. The wound was dressed and firmly plastered. The EBL was 350 mils. Estimated with BP 120/60 millimeter per mercury. The pulse was 81 beats per minute. The SpO2 the op finished at 7:00 a.m. The baby was seen by the PTOC and was nursed by the mother bedside. The status of the patient and the updates. The mother and the baby was discharged in a certain with our male baby. Thank you.
Thank you so much, Matron, and thank you everyone for following along with that interesting case presentation. Thank you so much, Prof. I see that you've already begun to provide some answers to the questions already. We would like to just take a minute or two to just get your expert insights to the case presentation that was just spoken about now. Thank you.
My main question there is I didn't get how the diagnosis of failed induction was made. I saw the time at which, she was examined and she wasn't progressing, but what time did she come into labor? I missed that, sorry.
She came to labor, the patient came to labor on the 19th.
Can we see that slide again?
And the induction was done on the 20th.
19th at what time, please?
I think around 11 a.m. Because
okay,
they normally come
here.
in the morning. In the morning, around 11
9 a.m. She was 3 centimeters.
Yes, ma'am.
Next slide, please. And then at 5 a.m. of the next day, she was not progressing. Okay.
Yes, ma'am.
So, I mean, I think there must have been other vaginal examinations showing that, nothing changed. And also, I mean, it looked as if her pulse rate was getting higher and all that. So it seems like a straightforward case. I don't know exactly how CPD was diagnosed, but it's possible that maybe when she was being examined, it was saying maybe there was some caput or something like that, and there was no progress more than, or maybe she stayed at 3 centimeters despite contracting, adequately. Those aspects are not very clear here. But as far as if she was diagnosed as being failed induction, then definitely she should have had the emergency CS as written here. And it looked as if the management was straightforward and appropriate. So yeah, thank you. Postpartum, I don't know if she was seen afterwards to ensure that she did her family planning and contraception properly so that she doesn't get pregnant again soon after, and also spaces her family and doesn't have too many children. So that counseling was just the only additional thing I'd want to include there. Thank you.
Thank you very much, Prof. And thank you, Matron, for sharing this case presentation. Thank you, Prof, for your expert insights and the additional recommendation it gave. I see that Dr. already also was inquiring if baby